Hi guys, today we'll discuss about some medicine MCQs. The first question is, a 49-year-old man has been recently diagnosed with type 2 diabetes and is being carefully monitored. He has been advised to maintain a healthier diet and lifestyle. He attends a follow-up clinic and claims to have been following the diet stringently since his last appointment 3 months ago. The most appropriate investigation is option A, random plasma glucose, option B, fasting plasma glucose, option C, urine dipstick, option D, glycated hemoglobin, option E, weight measurement. You read the question carefully and we'll discuss the answer. So in case of this question, the patient is maintaining the diet stringently, and the purpose for the investigation is to monitoring the blood sugar level. And the best blood test for monitoring blood sugar level is glycated hemoglobin, because in case of random plasma glucose, fasting plasma glucose, or urine dipstick, what do we find? We find the plasma blood sugar level, or in case of urine dipstick, the urine blood sugar level at the moment of testing, at the moment of testing. But in case of glycated hemoglobin, we can find the blood sugar controlling capacity of the person or the response to the treatment, as because in case of glycated hemoglobin, what we test the glucose that is attached to RBC, red blood cells. So we know the life cycle of RBC is 120 days. So if we test glycated hemoglobin, we can at least we can monitor the blood sugar level for previous 120 days. So for long-term blood sugar monitoring, the test is preferred is glycated hemoglobin. The next question. A 29-year-old woman is found unconscious by her partner and rushed to the accident and emergency. She is a type 1 diabetic and has maintained excellent glucose control using insulin injections. Blood biochemistry results demonstrate a moderately raised level of insulin, no detectable C-peptide, and very low blood glucose. Her partner mentions she is a lawyer and has been working particularly hard in the last week, eating quick meals and occasionally missing meals. The most likely diagnosis is option A, hyperosmolar coma, option B, diabetic ketoacidosis, option C, insulin overdose, option D, hypoglycemic coma, and E, autonomic neuropathy. Read the question carefully and we'll discuss the answer. So you have to find out the key points from the question. First, patient is diabetic, patient is unconscious. Second, patient is maintaining her insulin injection regularly. Patient no detectable C-peptide is present, very low blood glucose, and patient is missing meals. All of this indicating it's a case of hypoglycemic coma. Hypoglycemic coma. Why? Because patient is taking insulin but is not taking meal regularly. Okay, so it's a clear case of hypoglycemic coma. And what is the point of what is the important of this line? No detectable C-peptide. That means patient's indigenous insulin secretion is deteriorated, or there is no indigenous insulin secretion. All the insulin the patient having is the insulin injection from insulin injection. So that is the meaning of this line. The answer is D, hypoglycemic coma. I'll discuss about next question. A 6-year-old girl presents to accident and emergency with severe abdominal pain, nausea, and vomiting. On examination, the patient is tachypneic, capillary refill is 3 seconds, and she has a dry tongue. While listening to the patient's lungs, you detect a sweet odor from her breath. The most likely diagnosis is diabetic ketoacidosis, non-ketotic hyperosmolar state, gastroenteritis, pancreatitis, E. adrenal crisis. I think it's a easy question as because the key point is very obvious here. So in this question, the key points are severe abdominal pain, nausea, vomiting. There are the symptoms. Second, you detect a sweet odor, dry tongue, tachypneic. So it's a clear-cut case of diabetic ketoacidosis. What happened here? Actually, diabetic ketoacidosis is a catabolic state of body. What's happened? It as it perceives loss of energy actually, and what happens here? Fat getting fat breakdowns to ketone, and that ketone is responsible for the acidosis. Okay, and patient goes into a hyperventilate state. Hyperventilation is there as because patient want to cope up with the situation. This type of hyperventilation is called Kusalmo breathing, and that odor that is coming from the breath, that is actually odor of acetone. Acetone is produced to control or to neutralize the serum pH. So every line is important. Answer is diabetic ketoacidosis. We'll go to the next question. A 16-year-old girl presents with her general physician complaining of a swelling in her neck which she has noticed in the last 2 weeks. She has felt more irritable, although this is often transient. On examination, a diffuse swelling is palpated with no bruit on auscultation. The most likely diagnosis is hyperthyroidism, simple goiter, Riddle's thyroiditis, thyroid carcinoma, or thyroid cyst. So you have to exclude the options. So let's exclude the options. Hyperthyroidism. In case of hyperthyroidism, there will be some symptoms or sign. There is no symptom of sign mentioning here. And in case of auscultation, bruit will be there. So hyperthyroidism, that is excluded. Next, Riddle's thyroiditis. It's a inflammatory condition of thyroids, and usually when you palpate the thyroid, it will be stony hard. But in case of our case, there is no mention of stony hard palpation. So Riddle's goiter exclude. Then thyroid carcinoma. Thyroid carcinoma is a rare condition, and there must be some symptoms or sign is there. There is no mention here. Any symptom is there. Thyroid cyst. Fluid filled thyroid cyst will be a single presenting lump. But in this question, diffuse swelling is mentioned. Diffuse swelling you can never find in the thyroid cyst. It is a single palpable lump. So the answer is simple goiter. Patient is suffering from simple goiter. B is the answer. So next question. A 49-year-old woman attends your clinic suffering from chronic renal failure due to progressive glomerular disease. She appears well and her blood pressure is 141 by 92 mm of Hg. Blood tests reveal elevated phosphate, serum creatinine and urea, while calcium levels are low. Her estimated glomerular filtration rate is 35 ml per minute per 1.73 meter square. You also notice the patient's cholesterol levels are moderately raised. The most appropriate management is sevelamer parathyroidectomy, oral vitamin D, sinacalcet, renal dialysis. So as I always say, you have to find out the key points. It's a case of chronic renal failure. Okay. Second, elevated phosphate level and calcium level is low. Cholesterol level is also moderately raised. It's a case of secondary hyperparathyroidism due to renal failure. So secondary hyperparathyroidism. And why I am saying this, all the features are matching with the condition. Okay, elevated phosphate, lower calcium. So what you have to do, you have to clear out the phosphate, you have to lower the level of calcium, and you have to lower the level of calcium level, cholesterol level also. So sevelamer actually it's a phosphate binding drug. Phosphate binding drug. So this drug will bind phosphate from the gut and it will lower the level of phosphate, and eventually calcium level will increase, cholesterol level will increase. The answer is sevelamer. Sevelamer is a phosphate binding drug. Next question. A 21-year-old man presents with lethargy over the last week. He has periorbital edema and proteinuria. The patient mentions he has been to hospital a number of times in the past due to the same symptoms as well as mild eczema. Light microscopy of a renal biopsy showed normal morphology. Electron microscopy of the renal biopsy reveals the diffuse effacement of the epithelial podocytes. The most appropriate treatment is option A cyclosporin, option B no treatment, option C probenecid, option D renal transplant, option E oral prednisone. Read the question carefully and try to find out the catchy point or the key points. So catchy point here or key point is periorbital edema, proteinuria, then light microscopy that is showing renal biopsy is normal, but electron microscopy that's showing the diffuse effacement of the epithelial podocytes. So something is there. What is this? That is a, or mild eczema is also there. So that's a case of minimal change renal disease, minimal change disease. And the drug of choice in this case is oral prednisone or oral steroids. Cyclosporin is a reserved drug. If oral prednisolone or oral steroid is of no use, in that case we will use cyclosporin. But in this scenario, the medicine of choice or drug of choice will be oral prednisone or oral steroids. A 47-year-old woman has been experiencing a 4-month history of diarrhea and bloating. Associated symptoms include lethargy and weight loss. Full blood count reveals hemoglobin of 9.3 and MCV 70. Which of the following investigations would be helpful in the patient's diagnosis? Option A anti-mitochondrial antibodies, option B anti-smooth muscle antibodies, option C anti-tissue transglutaminase antibodies, option D anti-nuclear antibodies, option E anti-neutrophil cytoplasmic antibody. 4 months history of diarrhea and bloating. Okay, lethargy, weight loss, hemoglobin is also low. So patient is suffering from malabsorption, you can say, and the disease is most likely celiac disease. And for diagnosis of celiac disease, we have to do anti-tissue transglutaminase antibody. Anti-tissue transglutaminase antibody. There are several tests for celiac disease, but one of these, that is option C, anti-tissue transglutaminase antibodies. Read about celiac disease, it's your home task. Now next question. A 60-year-old man with alcoholic liver disease has admitted with an upper GI bleed secondary to esophageal varices. The patient undergoes endoscopic variceal bending and is discharged after 2 weeks in hospital stay. Which of the following medications would act as prophylaxis in preventing a rebleed from the esophageal varices? Option A, furosemide; B, amlodipine; C, ramipril; D, propranolol; option E, irbesartan. The patient was suffering from esophageal varices, and he was managed by variceal bending, endoscopic variceal bending. So what will be the prophylactic drug for preventing a rebleed from his esophageal varices? Esophageal varices is caused by portal hypertension. The medicine of choice in this case is propranolol. This is the answer. Propranolol. Whenever you are encountering this type of questions, portal hypertension, esophageal varices, read about these things. What are the medicines? What are the pathophysiology? Okay, then only you can relate the answer. Now the next question: which of the following gastroenterological conditions would give rise a finger clubbing? Hepatocellular carcinoma, ulcerative colitis, irritable bowel syndrome, hepatocellular carcinoma, pancreatic carcinoma. So what is the gastroenterological condition that will give finger clubbing? We know the other cause of finger clubbing, but in some cases, gastroenterological cases, we also see finger clubbing. So what is that? Answer is irritable bowel syndrome, IBS. IBS. It is also give rise to finger clubbing. And another gastroenterological condition, that is liver cirrhosis. That is also the clinical feature is finger clubbing. You were questioned by your registrar regarding bacteria responsible for causing blood-stained diarrhea. From the list below, select the organism which is not responsible for causing blood-stained diarrhea. Option A, Campylobacter species; Salmonella species; C, E. coli; D, Shigella species; option E, Staphylococcus species. Which bacteria is not responsible for blood-stained diarrhea? Campylobacter is responsible, Salmonella is responsible, C, E. coli is responsible, Shigella is also responsible. So all first 4 options is responsible for blood-stained diarrhea. The last option, Staphylococcus aureus, that is not responsible for blood-stained diarrhea. So the answer is option E. That is my today's last question. Thank you very much for patient listening.